Hello, my name is Jasmine Warren, and I am a Children and Family Services Specialist 2 supervisor with New York State Office of Children and Family Services. Today, I will be exploring psychotropic medication use and behavioral mental health services of children in New York State foster care, the promising practices, and psychotropic medication use. There's a robust agenda that includes my introduction, 13 and Me Visionary Guided Poetic Meditation, my PICO call to action, the historical background of policy and laws related to psychotropic medication use within New York State and the United States federal government, my participant interview, New York State strategies, my needs assessment survey, intervention, and the methodology, as well as additional findings. There will be a look at the strategic outlook and, of course, my amazing MPLD journey. So, my introduction, 13 and Me Visionary. At 13, I saw me. I looked in the mirror and saw a visionary. Can I take all of you on a journey with me? I would like to start with a guided meditation and invite all of you to close your eyes and picture taking a walk with me along the short blocks of the South Bronx streets. 13-year-old me fostered in the garden where shadows played. My sister, a 5-year-old bud, blooming, finding her way. Prescribed melodies of a pill's soft hum, her heart's journey, a tender drum. Beside this 5-year-old bud was 13-year-old me, acting as a sister's embrace, wise, a guiding grace. I had lasting pictures of my 5-year-old sister's buds, stunted in growth, zombie-like features, as psychotropic medications whispered. 13-year-old me, a guardian, wishing that I can see my sister's fate, holding a map to softer skies. Together we chased away the storms as we hid behind what became the norm, psychotropic medication and pill form. In my mind, I saw tiny hands, a fragile frame, nurtured by love, not just a name. Meds like petals, a delicate bloom, navigating shadows in a quiet room. Through all the hazes of the trials untold, a resilient spirit, brave and bold. In the dance of pills and childhood's glee, a tiny heart sought harmony. They were fostered by love, a sheltering light, and in year 2000, a New York Times article gave me light. Guiding through the darkest night, 13-year-old me vowed to change the trajectory. In the script of healing, there was irony. I vowed to make it my purpose to research, advocate, and expand my knowledge around medications, its implications, and the broader behavioral health challenges faced by foster children in New York State. I would like to welcome all of you to open your eyes and walk with me on the irony. I pursued a career in child welfare. I was adamant that I was going to be a medical doctor. However, my passion and purpose led me to a strong desire to affect change. And as a foster care alum, I started my 10 years of direct practice as a CPS worker with New York City Administration for Children's Services. I saw a brighter light thereafter, and an opportunity came forward to affect change on an administrative policy level through the New York State Office of Children and Family Services. I envisioned this opportunity would take me and lead me to my ultimate goals of being a change agent. creating effective policies amongst the child welfare population, intervening and controlling outcomes, which led to my PICO. If New York State Office of Children and Family Services enhances guidance related to best practices in managing behavioral health services, psychotropic medication uses of children in care through the creation of a video, desk guide, and checklist, will it help enhance the appropriate use of medication and agency assessments of mental health, behavioral health needs of children in foster care, ultimately increasing the likelihood that children will achieve and maintain permanency. Throughout this process, it was important for me to obtain background information on the policies and laws around psychotropic medication use of children in foster care. Through my research, I learned in 2008, the Fostering Connections to Success and Increasing Adoptions Act of 2008 was enacted. And this 2008 public law required state and tribal agencies to develop a plan for ongoing oversight and coordination of healthcare services for children in foster care. It also included the creation of a planned coordinated strategy to identify and respond to the healthcare needs of children in foster care placements, including their mental health needs. Also, in that same year, New York State provided guidance to all of the local District of Social Services and their voluntary agencies on the use of psychotropic medications for children and youth in placement and authority to consent to medical care. In 2009, the Children's Bureau issued guidance around addressing the oversight of psychotropic medications. And in 2011, there was an amendment to the 2008 Fostering Connections Act. And this amendment centered around adding to the requirements for the healthcare and oversight coordination plans for children in foster care. This 2011 law also required that the healthcare oversight and coordination plan outline the monitoring and treatment of a child's emotional trauma and health needs in foster care. Following that year, New York State OCFS participated in improving the use of psychotropic medications among children and youth in foster care. There was a quality improvement collaborative funded by the Annie E. Casey Foundation. And also in that same year, the Health and Human Services federal government organization hosted a meeting for state leaders to help them establish effective medication oversight practices. In 2014, the United States Government Accountability Office, also known as GAO, studied efforts to oversee psychotropic medications. So there were an abundance of findings from the state data. Research from the United States Department of Health and Human Services and the Government Accountability Office highlighted several factors related to psychotropic medication use of children in foster care, and they included behavioral concerns, placement type, geographic variation, age, and gender. I wanted to delve deeper into age and gender. In doing so, research findings reflected that 4% of all 2 through 5-year-olds taking psychotropic medication were children in foster care, and approximately 16% of 6 through 11-year-olds were prescribed psychotropic medication, and an astounding 22% of all 12 through 16-year-olds were also prescribed psychotropic medications. On The gender side, males in foster care were more likely to be prescribed psychotropic medications at an alarming percentage of 20% compared to 8% of their female counterparts. Further research and literature review from the Health and Human Services Organization and GAO revealed that children in foster care are more likely to have a mental health diagnosis than other children. And some of those common diagnoses among children were prescribed psychotropic medications, and they included oppositional defiant disorder, conduct disorder, major depressive disorder, major depressive episode, attention deficit hyperactivity disorder, and post-traumatic stress disorder. And those were reviewed as the most common diagnoses among children in foster care. Following my analysis of the historical background information of federal and New York State policies, I wanted to dive a little deeper into New York City Administration for Children's Services practices, particularly in the region of New York City. The goal was to look at the two factors of age and gender in relation to psychotropic medication use in New York City foster care. This particular graph shows background data from March 2022. The red bar graphs represents age group. In doing so, I learned 12 years old, children 7 to 12 years old represented 23% of the foster care population. Green represented gender. And I also learned that males dominated psychotropic medication use, with 486 children prescribed psych meds in relation to 372 children who were females. In March of 2022, the use of psychotropic medications increased approximately 3% within 1 year. This particular bar graph, shows data from March of 2023. The use of psychotropic medications increased approximately 2% from 2022 to year 2023. A total foster care population of 922 children in foster care were prescribed psychotropic medications, and that represented 15% of the foster care population. Again, in March 2023, I looked at the age group and the gender of children prescribed psychotropic medications, and I learned, again, 7 to 12 years old represented 25% of the foster care population prescribed psychotropic medication use, and males, again, dominated with 502 males prescribed psych meds in comparison to 420 females in foster care. Comparingly, the data around age and gender validated HHS and GAO's research findings from 18 years ago. And surprisingly, 18 years later, age and gender remained a major factor, with males dominating and psychotropic medication use prescribed in early adolescence between the ages of 7 to 12 years old. I also wanted to gather some background data for the years March 2022 and March 2023. So slides 12 and 13 will display background data on which psychotropic medications were most often prescribed or widely used. I compared years 2022 and 2023. Background data showed that prescribed psychiatric medications and attention deficit hyperactivity disorder, also known as ADHD medications, were widely used in years 2022 and 2023. Psychiatric medications were used for depression, anxiety, bipolar disorder, and ADHD. This data allowed me to compare and contrast the data of HHS and GAL collected 18 years ago. Depression, anxiety, ADHD, conduct disorders remain on the top of the list. From 2012 to present, the current data validated HHS and GAO's research, implying that there's still much more research needed around the why of psychotropic medication use among children in foster care as opposed to other mental health alternatives. Voices of lived mental health experience in New York State child welfare. There was a major important goal for me to interview someone with lived experience, mental health experience in particular. I was able to interview Dr. Felicia R. Wilson, who is a foster care alumnus. There is an importance of hearing individuals with lived mental health experience, and it was important for me to gain further perspective into the life of other children in child welfare. In doing so, Dr. Wilson afforded me the opportunity to create a video called Beyond the Clouds. This video was not able to be shown, but I was able to interview her and gain some information. I learned in 1988, at the age of 4, Dr. Wilson was in 64 different foster homes, was prescribed antidepressant psychotropic medication, which she used from age 6 until age 14. She experienced 3 failed adoptions in which contributed to her struggles with mental health. Dr. Wilson also reported reasons for stopping the antidepressants. And her reasons included she wanted to live a normal life, experience her childhood, and feel like her peers. Dr. Wilson reported while taking the medication, it was hard to experience regular childhood experiences. I also wanted to learn what supports Dr. Wilson had while in foster care. And further dialogue revealed she met weekly with sociotherapists and a psychiatrist. Dr. Wilson aged out of care in 2005. She expressed being afraid, alone, no educational or mental health supports. There were several important takeaways from this interview, and they included medication is not the end all or be all to a child's mental health journey. Medication should never be the first strategic move. Pushing forth therapy and other alternatives should be the first step. Fostering a collaborative approach, empowering caregivers, looking ahead, and having a compassionate tone is the key in moving the youth's mental well-being to the forefront. After Dr. Wilson's interview, it was important for me to review New York State strategies within the past decade. And I learned in 2023, New York State Governor Kathy Hochul invested $1 billion as part of a multi-plan to transform the continuum of mental health. One initiative within the plan included youth mental health summits. And these summits were conducted throughout the 5 boroughs of New York City and obtained New York's youth input and their mental health services and needs. In 2021, as part of the Family First Prevention Act, there was policy changes, and 21 OCFS ADM 05 was created. And this directive gave guidance on recent regulatory changes in conjunction with creation of policy-based standards of care that would continue to promote and maintain the health, safety, and well-being of all youth placed in all congregate care settings. New York State also collaborated, and this is OCFS, with New York State Office of Mental Health Services. And they collaborated to streamline Medicaid services around health services in New York State. And that included the creation of the Psychiatric Services and Clinical Knowledge Enhancement System, also known as Psychs. Psychs is a web-based platform developed by New York State Office of Mental Health for sharing the behavioral health population history, including psychiatric history, substance abuse services, and psychotropic medications. Individuals who receive services from a state-operated psychiatric center are able to be tracked within this database for data purposes. Although all of these initiatives were implemented, there appeared room for improvement. And on the state level, particularly New York State, OCFS, Child Welfare Community Services, a needs assessment was warranted. I was able to conduct the needs assessment. There were 27 participants within a staff survey. The demographics of the survey included staff from all 7 regions of New York State, and that included the Albany Regional Office, Buffalo Regional Office, New York City Regional Office, Rochester Regional Office, Syracuse Regional Office, and Westchester Regional Office. On this pie graph, Long Island is depicted by other. It was important for me to obtain my colleagues' level of understanding of behavioral health services and psychotropic use monitoring and oversight. The needs assessment consisted of 2 surveys, with the first survey depicted here on page 16 and the second survey on page 17, displaying staff demographics and the who's who of the regional offices. A total of 27 participated in both surveys, and the highest response rate of 33% was from the New York City Regional Office, with the second highest response rate of 33% from the Albany Regional Office. This demographic pie chart results reflected regional office support staff, which included Children and Family Services staff and New York State OCFS directors and commissioners. Participants included 33% of Child and Family Services specialists, which is quite important as they serve as the program leads of the voluntary provider agencies. They are the reviewers, the assessors, providing important oversight and monitoring of services within child welfare community services. How helpful would a desk aid be? An OCFS desk aid behavioral health services checklist would be a tool for provider agencies to use to improve permanency and possibly reduce placement permanency disruption. I wanted to survey staff, and one of my major questions was, how helpful would a desk aid behavioral health services checklist be in the monitoring and oversight of behavioral health services? 59% of staff surveyed that it would be very helpful to create a desk aid. And on the other spectrum, commissioners and directors responded with a whopping 90% saying very helpful. The creation of a desk aid would be important to move forward permanency options for youth. There were additional findings in my research, and I learned that psychotropic medication data complied from New York City Open data lacked the ethnicity, race of children of in foster care who were prescribed psychotropic medications. I also learned that New York State Office of Mental Health data obtained through New York State Psych's database reflected psychotropic medication that was complex and antiquated. It lacked ethnicity and the race of individuals, as well as concrete information related to children in foster care. My intervention, the OCFS desk aid, which would be a foster care casework behavioral health practice desk aid to provide checks and balances, facilitate permanency outcome, guide, and serve as a reference tool for the local district of social services, mental health providers, and voluntary provider agencies. This particular desk aid will present targeted information and improve agency measures by mapping agency strengths. The goal of the desk aid would be to improve permanency and possibly reduce placement permanency disruptions. My intervention also included a behavioral health services case process checklist. And this checklist would be used to enhance OCFS continuous quality improvement activities. It would also enhance current behavioral health guidance, child welfare worker engagement and relationship building. The checklist would allow OCFS to enhance data collection practices and provide a measure for internal tracking purposes. The checklist would also improve interdisciplinary coordination. The goal of the Behavioral Health Services checklist would allow OCFS Child Welfare Community Services to collect data to improve permanency practice outcomes in foster care. The strategic outlook, comprehensive assessment protocols, the enhancement of the health services window and connections, the enhancement and continuous quality improvements, ongoing reviews, advocacy and support services, a creation of a mandatory 1-year aftercare service for children who are adopted or discharged from foster care who were prescribed psychotropic medication use, along with the tracking system of those children. Collaborative decision-making amongst multiple state agencies, including the Department of Education, the Department of Mental Health, as well as OCFS. Policy improvements and adherence, research, and data analysis. The hope is that the desk guide and checklist I created would serve as a standardized assessment protocol across all of New York State that would inform data and improves permanency outcomes in foster care. The impact, my MPLD journey. I was able to develop a behavioral and mental health services desk aid and checklist. I approached and presented desk aid and checklist, my desk aid and checklist to policy, child welfare community services leadership, and New York State OCFS legal department. I learned that the policy department is currently updating the Working Together Health Services Manual, and the outlook would be for my checklist and desk aid to be included within the Working Together Health Services Manual that OCFS is updating. I was able to create a video and interview a foster care alum with mental health and psychotropic medication lived experience. My personal and professional growth within MPLD has been a journey, one that was dynamic and transformative. Prior to MPLD, I struggled with imposter syndrome, doubting my abilities, skills, and talents. Although I considered myself a visionary, I doubted my ability to actually see my vision through and affect change. So, what did that look like for me? Minimal dialogue in meetings, sitting in the background and holding on to my thoughts and ideas. I certainly did not know how to foster my growth and influence individuals through transformative leadership. This year and journey through the MPLD fellowship helped me identify my transformative leadership skills and learning styles. I was able to hone in on my skills and develop communication skills, enhance my strategic thinking, and cultural competency. I was also able to professionally network. And most importantly, pairing me with a mentor that exuded confidence and showed me how to step to the forefront, challenge and encourage me to reach the greatest of my abilities was dynamic. The Minority Professional Leadership Development Program provided real-life models in leadership positions, empowering me to break down multiple barriers to leadership opportunities. This is certainly not the end. I will continue my plight with hopes of furthering this action research project through an in-depth research opportunity. Keep an eye out. MPLD created an everlasting impact.